есть у него книги, переведенные на русский язык?
Да. Эксперт to эксперт. Вот там стойка у нас есть с литературой. Вы не подходили?
Подходила, не видела.
Нету?
Не видела.
Ну, вообще практически на всех конгрессах присутствует литература эксперт to эксперт. И по ботулотоксину, и по филлерам, по губам. Такая она узнаваемая с логотипом и to и. И есть они на русском языке переведенные тоже. На українському нет. Треба працювати.
Ще хотіла би додати до корекції носослізної борозди. В своїй практиці так само в мене спостерігається тенденція до зменшення кількості однозначно. І на рахунок медіального кутика було ваше запитання. Реденцій-2 дуже особливий препарат. Не тільки тому, що там на висока концентрація гіалуронової кислоти, що є сильно-гідрофільним, він містить в собі дермореструктуризуючий комплекс. Пам'ятаєте, так? Амінокислоти, антиоксиданти і вітаміни. Завдяки цьому дермореструктуризуючому комплексу ми і отримуємо ефект корекції темних кіл під очима. І в медіальному кутику інколи міні-крапельки достатньо для того, щоб забезпечити, власне, ефект освітлення. І не женіться за тим, щоб повністю заповнити западіння в цьому місці. Бо насправді наших пацієнтів турбує, власне, темнота під очима. Це вона додає змученості, це вона додає сумного виразу обличчя. І маючи в руках такий інструмент, як Redensity 2, ви використовуєте всі можливості дермореструктуризуючого комплексу з невеличкими кількостями.
Voilà, it's okay. Press on it here, a little bit, yes, flat.
Некоторые специалисты отказываются от использования Redensity 2, потому что им жалко тратить маленькую часть препарата на корректируемую зону, и они не знают, куда использовать остаток дорогущего препарата. Ну вот очень, поскольку у нас сегодня тема такая по нижней трети лица, мы пройдемся с Людмилой, то вот как раз очень хорошее место, куда его можно прекрасно пристроить, используя для дела, это как раз губы. Вот, потому что, как Людмила сказала, дермореструктуризирующий комплекс внутри Redensity 2 позволяет нам не только сделать такое легкий филлинг области красной каймы, но и лечить эту зону, потому что проблема сухости в области губ, она
Everybody smile now.
Женщинам вижу, с которыми чаще контактирую, в первую очередь со своей супругой. Вот, она все время, у нее припадок, если она не может найти этот бальзам для губ. Так что очень можно туда это использовать.
We say in France, when you have some risk of hematoma, you press 5 minutes, but 5 minutes is very long when you press. No, it's okay, it's finished. Finish, okay.
У меня вопрос по поводу комбинации ультрадип и РЧ4. В случае, если мы маскируем маляр и просто усталый вид и начинает опускаться компартмент жировой, да, щечный.
And I will say zoom and dezoom, so I need first to zoom on this part of the face because I will draw the anatomy, okay?
Дякую за запитання. Дуже актуальне запитання, тому що
I will turn
насправді
your
у нас
face.
у
It's okay
слов'ян
like this?
дуже багато пацієнтів, які мають набряклий інфраорбітальний жировий пакет, тобто маляр.
Okay, very
Це є
good.
проблема, і всі наші дії повинні бути скеровані на те, щоб його закамуфлювати, а не підкреслити. Тому в своїй практиці за умови наявності такого застійного маляру, я все-таки буду вибирати супраперіостальне ведення ультрадіпу, чітко в ті місця і в ті точки для того, щоб закамуфлювати маляр, і або взагалі не буду використовувати РЧ4 в поверхневі жирові пакети, або якщо мені це потрібно зробити, я буду розкладати його нижче, лінійно ретроградно, віялоподібно, в дуже невеликих кількостях, тому що, звичайно, якщо в ділянці маляра ви розташуєте динамічний волюмайзер, навіть який можна вводити поверхнево в поверхневі жирові пакети, ви все одно, звичайно ж, посилите пастозність і набряклість цієї зони.
Спасибо.
Я тоже придерживаюсь такой техники. Больше поддержка в глубоких слоях. Мы часто думаем, или пациенты, или специалисты, мы часто думаем, что вот там эти малярные мешки, они появились. А они на самом деле не появились, они как были, какими были, такими и остались, просто под ними уходят глубокие жировые пакеты. Поэтому, конечно, мой выбор тоже коррекция сначала супрапериостальной области.
И следующий вопрос.
Есть еще вопрос, уже у нас видео появилось. Вы видели, там было пару кадров, Патрик делал анестезию пациентке подготовительную.
Do you hear me?
На связи, да, с комнатой.
Do you hear me? Yes?
We hear you,
Okay,
Patrick.
good. So this is my patient. So first, you remember ATP, so anatomy technique products. First, I will draw on this patient the anatomy on the left side, and I will explain to you on the right side the technique I will use. So if you are looking to the danger of the face, you have two areas where you can palpate the danger. The first is the mandibular line here with the facial artery. You can feel it on you if you put your fingers here. And this facial artery is located at the front of the masseter muscle that is just here. So this is my facial artery, and this facial artery is going up slowly here. It's very deep and going and go in the nasolabial fold like this. And after is going in the nasojugal depression here. So this artery is moving up here. So as you can see here, this nasal artery is here. Become the angular artery. And after is going along the nose like this. And here, this artery perforates a muscle called the depressor supercilii and become very deep, and here going up in the forehead. This facial artery, if we zoom a little bit more, and give the lateral nasal artery here, and give also what we call the nasal artery, that is just like this. This artery has different layers. If I take a dark pen, I will draw you horizontal line, and this artery, if I draw this line here, under this line, my facial artery will be deep. Above this line, my facial artery will be superficial. And when my artery crosses here, the depressor supercilii, then my artery will become deep. And 2 centimeters above the eyebrow, at this line, my artery will become superficial. So this is the path of my facial artery, but my facial artery can follow also my facial vein, and so you remember that you have the nasolabial fold, but you have also here what we call the nasojugal groove. And this nasojugal groove, it's exactly the place where is the facial vein, but in 20% of the cadavers, this facial artery here follow not the nasolabial fold here, but will follow the mid-cheek groove. So in 20% of the cadavers, the fascial artery will be along this blue line here with the same depth. It means superficial above this line, deep under this line. Why Mother Nature give us the fold? It's because you have ligaments, but this is not because Mother Nature gives the fold. It's because Mother Nature put the vessels here in the fold, because the fold, it's a fixed area, so the vessel during the movement can't move too much. If your vessel will be in a very mobile area of the face, the length of the vessel will be the double with the movement or without the movement. But this is not for that I do this remark. It's because each time in the face you have a fold, be sure that under this fold you will have a vessel. So when I see some people who do direct injection with the needle in the mid-cheek fold to lift this mid-cheek fold, it's not a good idea regarding the safety, and it's not a good idea to lift an area where you have a ligaments. So you have this depression not because you have a fold, it's because above you have a depression. If I'm going a little bit, with the muscle on the face, you will have here the zygomatic muscle, and this zygomatic muscle in green will join the corner of the mouth and the lowest peak of the cheekbone here. But the fascial artery will be under this muscle, because you remember the zygomatic muscle is just below this dark line here. And if I draw now the branch of the fascial artery going to the lips, you have a branches here, that is the arteria labialis superioris, and this arteria labialis superioris will cross the muscle 1/3, 2/3 of the lip to go in a submucosal position between my red dry and my red wet lip. So if I want to draw my vessel here, she will be just here at the junction between my red wet and my red dry lip. If I'm looking to the arteria labialis inferioris, it's totally different, because this arteria labialis inferioris is not a danger, because she's running like this, superficial, but be in the fold here, and we'll put some vertical vessel here to the lips in a submucosal position. So it's not a terminal artery like this one. And if I draw another muscle, you have here a muscle that you will see with the other speakers here. This is the DAO, and the DAO cover my arteria labialis inferioris that is deeper than this muscle. So here you see the vessels, you see the anatomy, the danger. Last point, I will draw you the point of the nerves. If you put a line, if the lady open her eyes, look straight, you see the mid-pupillary line here. And if you draw the mid-pupillary line, that is here, here, and here, you have just a little bit medial to this line. It means here, here, and here. you will have the 3 bone foramen of your supraorbitalis nerve, infraorbitalis nerve, and mentalis nerve. So you have exactly the drawing in 3D I show you with, for example, the malar area here. You see that there is no vessels. People speak with me about, you know, the transverse artery of the face. That is an artery that is below the zygomatic bone. It's going here. So it's really not a danger because this artery finish around here. So when you inject here, you can go with a needle, you can go with a cannula, you can go with your hand, with your foot, I don't care. You are safe here. But as soon as you go below the mid-cheek groove, then you enter in the dangerous area. So this is, I will keep this anatomy just for you. If you don't remember very well, you will see the patient on one side with the anatomy, and on the other side, I will show you the technique I use. So for that, you remember, I need to draw the line I will keep for me in the anatomy to understand the anatomical feature. Here, you see here a little, you know, line I will draw with my dark pen. This is my temporal line, my temporal crest. Here, I palpate between my 2 fingers my orbital margin, and here I palpate here my zygomatic bone. So you have your anatomy, and there is one area where you can palpate the danger in the mandibular line. This is the facial artery, you remember. But you have another area where you can palpate the danger. It is the temporal artery. If I put my fingers here, and you can put on your own temple area, you will palpate the danger. So if I do the drawing with the red, you know, pen, I can feel, you know, this artery. Why I mark this artery? Because if you do a gunshot, try not to be in this vessel here that you can palpate, or you will have a bruising. It will not be dangerous, but you will have a bruising. So in this case, you will palpate, you know, your danger, and on this place here, I see that there is an artery here, so I will do my gunshot technique a little bit backwards, straight to the bone, touch the bone slowly, smoothly, and inject half of a syringe. Then I go to the mid-cheek. Mid-cheek is very easy. If you draw a line, you remember this is the orbit margin here. If you draw this line vertically, like this, I call it the vertical line of the face. This vertical line of the face will limit the medial face and the lateral face. But this face here, this is where you have all the ligaments. Here I have the zygomatic ligaments, and here I will have the mandibular ligaments. Here I will have my medial souph. Here I will have my lateral souph. And to draw where is my deep medial cheek fat, I will draw here my mid-cheek groove. And you remember, I will show you on the other side, you remember the zygomatic muscle? Okay? We'll draw the zygomatic muscle here, and this is my third line. And here you have all my deep anatomical feature, lateral souph, that you will have not to inflate too much with male patients, but more for female patients. Medial SUF, and here, the deep medial cheek fat compartment. So you see the technique is very simple, and with these 3 lines, you have all your anatomy. Last drawing, I will explain a little bit more my French kiss technique, but the French kiss technique, I divide my lips here in 3. 1, 2, so 1/3 medial, middle third, lateral third, same here. I do the same on the other side. And then I will explain to you at the end how I do this injection. So you remember the order. I will start with the upper face. I will move to the mid cheek, and I will finish with the lips. So for that, I will use first my ultra deep with my gunshot technique. So I want to decrease the depression here. So I will use, and you are very lucky because in the ultra deep blister, we put 2 years ago a long needle. If I was using a short needle, this short needle will not reach the bone. So the advantage to have this in your blister is with this long needle, you can go directly to the bone for sure. So here you go, you need to be perpendicular to the bone. You go straight, slowly, always slowly, and here I touch the bone. If you believe in it, you can do an aspiration to see if you are in a blood vessel. It's not the case. And I will show you that I will inject this patient very slowly with 0.6 ml of product. So it means I will put half of my syringe. I slide a little bit on the bone to have all the bevel down. And I will go very slowly. I don't know if you see, but it's a slow motion. Why? It's because I don't want my patient to feel the pain. So pain is the first break. Do you have pain? No, pressure. So I go slowly. And I will push 0.6 ml of product here. And my patient will do the job for me. What does it mean? It means that my muscle will do the job, will do the massage of this zone. And you have to tell your patient that she will have some pain, a little bit, during 2 days when she will chew or eat, something, because the product is behind the muscle and will give, sometimes a little bit of pain. So I press, I finish. I did 0.6 ml of products, as you can see in my needle. And because I touch the bone, I will ask my assistant to change my needle because the bevel of my needle has been hurt by the bone, and so I need to change. So she will change my needle. And I will go. So as you can see here, you see here that, yes, with the other camera. Here you can see that I feel all this area. So I will now do my job for the 3 deep fat compartments. I put some little drop of products. So if I use blue HA, I bring here for you. I will put a spot here. I will put a spot here. And my last spot will be here. If I put the spot on my patients where I put my deep HA, it was here. Okay? This is how I will do. And just to show you how I will finish, I will put, in the tear trough, very, very small aliquot of product because she has a depression, but a very, 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 very small one. So this is my plan. This is how I will do my injection. But because I want to reach this deep fat here, I can do the technique I want. Trust me, you can use your own technique. You don't need me. You need only to be sure that your technique is safe and efficient. So I can do a bolus technique. So it means here, I can go here deep to the bone, deep to the bone, deep to the bone here. I can go with my needle here in the tear trough, but here I will use my needle to do medial souffle, lateral souffle, deep medial cheek fat compartment, and I will use a cannula to do my tear trough injection with redensity 2. So I will remove my blue HA, and I will do the job with my needle, but I can use a cannula. I don't care. So I will remove my tear trough, And you see that for this area, I use to fill this area 0.2 ml, not more. Yeah, and it's huge, 0.2 for me. So normally, I don't use a lot of product in the tear trough.
Can I drill a little bit?
Yeah? Yeah. Take your time. No, it's okay. So I will start my injection, and I will start with, you remember, I did 0.6 ml of product in the temple. So in my syringe, I have still 0.6. So I will do 0.2 here, 0.2 here, and 0.2 here, very deep. So for that, to be deep, if you use a cannula or a needle, you start in this area here. You will be deep along the bone. Here I'm along the bone, following slowly the bone, and reach, this area. And I will inject in this area 0.2. So you see how it's inflating here. I'm sure I'm deep, and I'm sure I will be efficient. Then I will withdraw my syringe, and I put here 0.2. It's done. And now I will go here, and I will put very deep in the deep medial cheek fat compartment 0.2 ml of product. So I lift a little bit, and I push 0.2. So I remove my needle. No blood because you are very deep. And if you check, one side and the others, but I will finish with the tear trough. But you see you have not a lot of bruising. And you see the difference. If you can check face, you see the lifting effect on this side. Can you check face with the other camera? A little bit. I will put the face here like this. Okay. You'd see that the little secret of this case is that if I put my cannula, this is redensity 2. Okay. If I put my cannula and I show you with the cannula where is, you see the difference between how this is high and this is low here. You see the big difference. Why? Because there is a big mistake when you do this injection of the mid-cheek. A lot of people, because they feel safer, they will inject where is the bump here. But the souffle is not here. the soothe starts below the orbit margin. So when I do my injection on this side, my products were there and not here. If you inflate here, you will inflate this bump and you will increase the concavity above. But the soothe is below the orbit margin. So if I do a drawing of my orbit margin, look up. If I feel under my fingers, my orbit margin is just here. Okay? And so where is my soothe? My soothe is here. And this is where my soothe disappears with the aging process. Here and here. So I need to put my products here and not here. Or I will increase the palpable malar groove that here. It's for that if you are looking to the patient face with the other camera, you see that here I create the bump, I create the lifting effect. Look at the nasolabial fold and the other. You see the difference. On this side, the face look up. It's not a lifting effect, but it's really a question of volume. Then I will do my tear trough injection. So for that, I will do my cannula injection. And the first thing to check is the length of your cannula. Because if you can't achieve with a good length the end of your tear trough, you will let the darker space here with no products. So I will start, with my entry point. So I draw the line because my cannula is straight that is going to the tear trough. So my entry point will be on this line. So I go here. And what is very important is that my entry point gives me the depth, and the depth needs to be deep, so on the bone, and the direction. It means my direction will be my tear trough. So when I do that, when I do hands-on, I said to my resident that my needle needs to keep like this if you are deep. I will show you if my needle is not deep, what happens. When my needle is deep and gives the direction, my needle keeps this angle. If I am more superficial here and give the direction, my needle will move. So it's for that, it's a little trick to know where you are. I remove my needle here. And then I will go straight to, this little hole, touch the bone here. You see I touch the bone. And after, the process will be very smooth. It means you don't have to do a lot of things. Your patient will need to feel nothing. Do you feel anything? And I will go on, and here I will ask the patient just to look up, just to check. You see where is my cannula? My cannula is just at the beginning of the tear trough. So my cannula is leaving the soothe and going up in the tear trough. And I will start to inject slowly. And if you encounter any resistance, my advice is to do a small aliquot of products just to allow the cannula to progress. Because when you put some HA at the tip of your cannula, you will create a space where your cannula can slide. So I will do it a little bit above because it's a nasojugal groove and the tear trough. So I'm going up here, always slowly, small aliquot of products. So it means small quantity to my patients. And like this, my patient, I will feel all this area, and after I smooth, you know, with my fingers, but I don't do a big massage. I want just to place the product and just to smooth this area. I don't want to have any bumps here, so I don't want to do any massage because my product is on the bone. If you face your patient and you look one side and the others, and I remove here my drawing, you can see the darkness on one side, and on the other side you see how you correct, you know, the darkness here, and how you keep here. No, you don't change your camera, keep the same one. You see the depression and the darkness on this side, and here you have no more darkness. So this is how you can correct, you know, this area. I will do the same on the other side, so I will go a little bit faster. I will use my gunshot technique, so I will remove a little bit my drawings here. I will do my disinfection. I will change my needle. I will take my ultra deep. Go straight with a new needle here. So you remember, perpendicular to the patient, go straight here. Touch the bone. Aspirate if you believe. And inject slowly. Slide a little bit as you see. And going slowly to inject 0.6 ml of products. So I go very slowly. I think this is a part of the secret of non-painful and of less bruising, because at the tip of the needle, at the bevel side, if you push too much, too fast, the movement of the HA will be like helicoidal movement. And so you will create more bruising for your patient. So I like to go very slowly to avoid, you know, this bruising. So here, I've almost finished. Here, 0.6, it's finished. I remove my needle. I was not in an artery, so I have no bleeding. I check. I did my entrance point with a non-bleeding. I change my needle, you remember? So gunshot technique take you 5 minutes in your office. Mid-cheek injection take you 5 minutes in your office. So your technique needs to be first safe, reliable, with a good outcome. But if you can go a little bit faster than the other, it will be better. So here, I turn the face. You remember the vertical line of the face here, mid-cheek groove, zygomatic muscle. So I know I will put here, here, and here. So you see one here, 0.2, 0.2, 0.2. So I go here, straight to the bone, deeply, slide on the bone in the upper part here, not here, and I will inject 0.2 slowly. I will go backwards. I will inject 0.2 also. And I will finish with here the deep medial cheek fat. So I push a little bit up like this, and you inject 0.2 ml of products to finish. That's all. Then you remember, I will just do now my tear trough injection. So if I draw a line, no, it's me. Here you see the line of my tear trough injection. So I will put my entrance point here. So I do my entrance point first. Do you have pain? No, it's okay. Nibelnier with me. So here, I use my needle. So here, my needle, my entrance point. Go deep and go and give your direction. So it means your needle stay fixed because you are deep and with a good direction. And I take, you know, my cannula. I remove my needle here, and I will do on this side a deeper. Here I feel here that I'm on the bone, and then I go a little bit like this, and you can rotate a little bit, but normally you are in the souffle, so it's a very smooth area. And so I ask my patients always to look up just to see really well where is my cannula. I will inject 0.4, 0.5. Okay, I finish. I will not put more. And now I will just go to explain to you the French kiss technique. So she will press a little bit here. Yeah, I will remove all the drawings. You can remove. So I remove my drawings here. I don't know if we are on time. It's okay for me? Yes? So I will show you now the French kiss technique. So you remember I want to inject in a safe area with a needle. And why I do that with a needle in a dangerous layer, because the submucosal, you know, area is a dangerous layer, it's because I want to rotate the lip. My patient, when they arrive to my office, they say to me, Patrick, what I want, and they use their fingers. They say, hey, look, I just want to do this. I don't want more. So when they do this, they rotate the lip, you know, and they everse the lip. So it means it's a rotation on the axis of the lips. So in this case, I will use a needle to be precise, and I will inject, you will see when I will do it, 1 syringes of RHA2. Why I use RHA2 is because I want my products to do like a bump, and I will show you the bump I create, but I don't want this bump to remain, and so I just want this bump to be scratched by my massage. You let a little bit the dot, like this, that's good. So how I do that? I use RHA2, and it will be, to summarize, a 6 bolus technique with a needle. And you remember that in the submucosal plane, my artery will be just here between my red dry and my red wet lip. If we can zoom on this camera, the same, no? Yes. You can zoom a little bit more. Yes, very good. A little bit more, very good. So you see here the junction here between the red wet here and the red wet, sorry, here, and the red dry lip here. So my bolus will be above this danger, in really the submucosal plane, but above 2 millimeters above the line between the red wet and the red dry lip. So for that, I put my finger, the pulp of my finger, and the pulp of my fingers will locate the exact location and safe location of my bump. And I will target with my needle, I will target, you know, the pulp of my index. So I go through the white lip, so I do it straight. And to be sure I'm submucosal, I need to feel on my pulp a little bit. It's for that I do this movement here. I move a little bit my needle just to feel on the pulp of my index the tip of my needle. It means like this, my products will be in a submucosal position. So I will inject slowly 0.2 ml of product. So I do a bump of 0.2 ml of products. So this creates a bump that you will see on this side. You see the bump here? Then I will go a little bit lateral and I will do a second bump at 1/3, 2/3. So I will target here my finger. I will feel it by the movement and I will inject 0.2 ml of products. It's done. Look, you have another bump here. So I have two bumps I can feel for this patient. And if I show you face the patient, you see that you rotate the lip up and you don't have the same on the other side. So I will do the same here. So I put my fingers, feel the safe area, go with my needle, straight through the skin, straight to my finger, feel it with the movement here, and put 0.2 ml of products here. But you need to feel the bump under your finger. So this is the right location. Then I go here. You see the bump here? You see very well the bump here under my finger. Then I go on the lateral side, the last point. I'm going here, deeply, straight. Feel my needle and inject slowly. .2 ml of product. So I use 0.8. And now you remember the balance. I need to go deep to the lower lip in a submucosal position. I do a little massage here. I can do a massage because the patient don't feel, you know, any pain because I did a transcutaneous, you know, injection, and I have the Lido in the product that allow me to do a strong massage to avoid the bump. So when I do like this, I do a massage just to avoid any bumps. So like this, I create an eversion of the lips like this. You see the outcome. You remember before how she was. And I keep in my syringe something to get in the lower lip. So you see the eversion movement of my upper lip. It means I don't inflate the white lip, I rotate my red lip. And now I will do the two last points of the lower lip. I do the same. So I put my fingers in. You see where is my point here. I just go through the skin, straight to the mucosa. Just feel on the pulp of my index the bevel of my needle. Don't go through the mucosa, but trust me, when you start this technique, sometimes you will have some HA on your glove. It's normal because you cross the mucosa. I inject slowly here. I will create a bump. Here, I did the bump. I will show you. The bump is here. You see the bump here? You see on the screen? Here, I create a bump. Then I turn the head of the patient. I will do my last point. I've still 1 ml of products. I go through the skin, straight, feel it here, and I will inject slowly the rest of my products. And because you cross the skin, I will do a small massage now. And because I cross the skin, my patient will not have a lot of bruising. When I was doing the same technique with a cannula or with some injections through the mucosa, I had a lot of swelling. Here, I will show you after. I will show first to my patient because she's very upset by the fact that I will do a French kiss technique and not a Russian.
A little bit preoccupied.
Yes, preoccupied. No. Chuchuk and malinki injection. So give me the mirror. No, stay like this. You see, it's very mobile because I use RHA2 and I want to show her. Do you like it?
Yeah, it looks cool and very easy. And it doesn't hurt because usually it hurts.
She had experience before and she had pain. But with this technique, you have no pain. And then I will use the post-procedure cream. Don't forget. Why? Because I go, you see, on one side, it takes me 10 minutes to do this injection. 10 minutes to do a lip injection. And because I go fast, and my patient loves to stay with me in Paris in my office, I always finish with the massage. And trust me, they love Patrick massage. And so like this, you know, they have a good moment with me. I don't inject, I'm relaxed. And so they feel better. Keep this time. I don't put no more IC pack because I feel I had some trouble with IC pack with a movement, you know, of the vessel with a contraction and vasodilatation. So I prefer now to do a massage to my patient just to avoid, you know, the bruising. And I use the post-procedure cream. I don't know if you know this cream, but I use it. This is this one you can have. And this is very, very nice. And after, I say to my patient, you will have to do your own massage. And they always ask me how long, how many times. And I say it's the rule of 3. So it's 3 minutes, 3 times by day, during 3 days. Full stop. You see?
Something?
Yes.
I want to say that my lips actually touch by the tongue, you know, they feel bigger, but I don't see that they actually
Yeah.
are bigger. This is nice, you know.
This is because, yes, this is because the injection, as you can see, has been done through the skin, so you don't cross the mucosa, and so you can see like this, you know, the shape of the lips. So the shape of the lips, you see, rotate. You have an eversion. You don't have, you know, an increase of the volume. And you see here, how her face, you know, for the tear trough and the mid cheek look great, and here also. So if I put my patient in a standing position and look at the patient, you know, on one side here, as you can see. So to summarize, I treat here with half of a syringe of ultra deep, half of a syringe of ultra deep, just to give her, you know, here the shape of her face, and here one syringe with half, you know, 0.8 milliliters here and 0.2 here.